but I'll just show you tutorial version of each arrhythmia also. And it is better to write how to manage each and every one at the immediately the causative factor and then the management of each and arrhythmia, so that it will be a concise answer which will be easily appreciated by the examiner when they correct the paper. If you mention the arrhythmia, then the causative factor, then the presentation, then the management. If you make it the answer like that, it will be a more appealing answer than giving the overall picture of all this. Okay.
Okay, sir.
Visible?
Visible, sir.
The normal cardiac electrical conduction starts from the cardiac action potential and is generated by through the mainly the ion channels in the cardiac cells. And this is all the basic thing that all of you know. And this is the normal VCG complex. How you get the PQRST. And then these are the action potential of, is it the cardiac myocyte action potential or SA node action potential, pacemaker action potential?
So, muscle action potential, sir.
This is cardiomyocyte action potential. Okay, because this has got these four phases. What are the phases that are absent in pacemaker potential?
The phase 1 will be present, phase 2 and phase 4 will be present, sir. The phase 1 and 3 will be absent, sir.
Okay, so it's a straight upstroke and then it goes to, this plateau will not be there. Okay, so it will be just like a, almost like a QRS complex, go up and then come down straight away. So the mechanisms of arrhythmia are roughly divided into three categories. One is what is called the increased automaticity due to reduced threshold of the action potential or increased slope of phase 4 depolarization. So this action is mainly because the cardiac myocyte activity. Then there is a triggered activity due to after depolarization reaching the threshold of the action potential. And the third mechanism is what is called circus movement or re-entry. So these are the three mechanisms of the arrhythmia occurrence. Increased automaticity, triggered activity, and circus movement or re-entry. Now, causes of intraoperative arrhythmia, you can classify them into patient-related, surgical procedure-related, or anesthesia-related. So that is how we classify them. So the patient-related factors are elderly patients. They can suddenly develop a arrhythmia de novo without any previous history of anything, or they may have a existing cardiac disease. Already they may be having a coronary artery disease or a hypertensive heart disease, so which are all more prone for development of arrhythmias. Then they can have intracranial diseases also, which may exhibit as an arrhythmia. This is a very important silent cause. They may be harboring a what is called normal pressure hydrocephalus, right? That may be present in the elderly age group, and that may exhibit as an arrhythmia, or abnormal blood gases or electrolytes. These are also considered as part of that. What you classified as metabolic can be all brought under patient-related causes. And surgical related, it is usually present during cardiac surgery when they handle the heart, or it can happen during dental procedures also, and or it can happen after ophthalmic procedures, especially strabismus surgery is notorious for that, producing a bradycardia, or it can be peritoneal stretching procedures, or it can be orifice dilating procedures like maximum anal dilatation for a fissure or a DNC. And central venous cannulation also can stimulate and produce a arrhythmia. And coming to the anesthesia related, endotracheal intubation or anesthetic agents. It may be volatile or muscle relaxants. All these things can also produce that. So that can be classified as this and presented in your exam. Now this is another way of presenting the same thing. Patient characteristics, pathology, the position. Sometimes the change of position also can induce an arrhythmia, like prone position or lateral position. And the pharmacology, like drugs or which are all used, both anesthetic agents as well as cardiovascular agents like vasopressors, inotropic agents, even reversal agents, local anesthetics. All these things also can induce an arrhythmia. And surgical procedures. So these 5 P's is another way of presenting the causes as well as the uh, reasons, or mainly the causes for arrhythmia. Now, intraoperative arrhythmia identification is the first one to do. So you must first find out what is the heart rate, whether it is normal, whether it is slow or very fast, whether the rhythm is regular or irregular. Sometimes it may be regularly irregular or irregularly irregular. So depending upon that, you must find out whether it is regular or irregular. And when there is a ECG monitoring is done, you must see whether the P is present and it is followed by a QRS complex. And then find out whether the QR is normal, shortened or widened. Then if there is some associated with hemodynamic instability. This is a very, very important factor to decide whether we are going to actively, aggressively treat the condition or not. So any arrhythmia, you must always look at this factor before you decide the treatment, whether the patient is hemodynamically stable or not. And does the rhythm require immediate treatment? So that will depend on the patient's hemodynamic stability. Now coming to the various arrhythmias, sinus bradycardia and sinus tachycardia are the commonest so-called arrhythmias under anesthesia. So bradycardia is defined as heart rate less than 60 beats per minute. And the causes of sinus bradycardia are vasovagal stimulation, hypoxia, hypothermia, endotracheal suctioning, and raised intracranial pressure. Another important cause which should not be forgotten. And if the patient is hemodynamically stable, what you need is only observation and see whether it gets corrected by itself or not. On the contrary, if there is a hemodynamic instability like low perfusion with low BP, then you have to either treat it by pharmacological method or by temporary staging may be required in cases where the sinus bradycardia is due to a heart block or conduction defect. And the pharmacological agent of choice is intravenous atropine, 0.5 milligram, sorry, IV, and it can be repeated every 3 to 5 minutes up to a total of 3 milligram you can give. But what is the disadvantage if you go to this particular level of 3 milligram? Are you hearing, Dr. Damodaran?
Maximum dosage of atropine can be given over time, sir.
No. You have to say, supposing you give 0.5 and it is not responding and you go on repeating and you give a maximum of 3 milligram, what is the disadvantage of that? Even if the heart rate comes back to normal, are there any disadvantages in giving this maximum permitted dose of 3 milligram? What are the other actions of atropine apart from stimulating the heart and producing an increase in the heart rate? Are there any other effects of atropine in the body?
Anticholinergic syndrome, it will rise, sir. Causes.
It will produce severe dryness. Okay?
Severe dryness. Yes,
the patient when wakes up from anesthesia, they will have extreme dryness. That will be very, very annoying. Okay. And they may, body temperature may go up. Okay? All the features of atropine toxicity will happen if you give up to 3 milligram. Okay? Okay. So you have to be very watchful to see whether it is really required. And in case if it is not responding to atropine, then the other pharmacological agents you can try are isopropanol, dopamine and dobutamine, and finally epinephrine, of course in diluted fashion, not in a high dose. Then the bradycardia degenerates into asystole, then cardiopulmonary resuscitation should commence and all facilities for patient should be kept ready. Then sinus tachycardia, which is defined as heartbeat more than 100 at resting state in an adult, and maximum heart rate 220 minus the age of the patient. Why? What is this formula called? Where is it used? Maximal.
What is the normal heart rate of the patient in pediatrics and in adults to differentiate? What is the normal heart rate at the age?
No. This is considered as the safest age limit, the heartbeat that any patient can have. It is 220 minus the age of the patient in years. Where is it used or where is it applied? Which protocol you use this formula? This is called Bruce protocol. Where do you use Bruce protocol? Anybody else?
Treadmill test
Treadmill testing, excellent. So you use this formula to set the target heart rate. So when a treadmill test is done, for example, if you do a treadmill test for a 70-year-old person, then the target heart rate will be 220 minus 70, which will be 150. Okay. So once the person's heart rate reaches 150, you have to stop the treadmill test so that the rate-induced pulmonary edema will not happen. Okay. So this is the importance of this particular formula, which is called the Bruce protocol formula, which is used especially during treadmill in elderly people. And the causes of sinus cardia are surgical pain or antimuscarinic agents, chronotropic agents, inadequate depth of anesthesia. All these things can cause sinus tachycardia, and you must identify that when you want to treat that. So treatment of sinus tachycardia basically is the correction of causative factor. Then you can use short-acting beta blockers like esmolol, which have a very short duration. You can repeat it if necessary to achieve the desired heart rate. Now, after these two common arrhythmias, next comes the AV block. AV block can be caused by intrinsic cardiac diseases or perioperative ischemia, electrolyte abnormalities, excessive idle tone, or iatrogenic causes, including surgical aortic valve replacement, where you can injure the conduction system. So all these things can be the causative factor. Majority of intraoperative blocks are transient and do not require any pacing or any active treatment. But AV block is classified, as you all know, into first, second, and third degree. The first degree is considered as very innocuous, does not require any treatment. It just shows a constant prolongation of the QR interval. What is the normal PR interval value?
1.2 seconds, sir.
0.12.
0.12 seconds.
Okay. Right. So it may go up to 0.2 seconds. Then that is called the prolongation, and this will be a fixed prolongation. It will not increase or decrease, and that is considered as an innocuous condition. Second degree, of course, it is divided into type 1 and type 2, and type 1 it is a gradual prolongation, increase in the prolongation of PR interval, which ultimately one beat gets missed. And the other second one is the couplet, which happens after every 2 or 3 beats, one beat will be missed like that. And the third degree is the most riskier or dangerous thing, where called also the complete heart block, where P waves are in discordant with QRS waves. There is no QRS following a P wave, and pacing is maybe required in these cases when the heart rate is less than 40 for a heart block, complete heart block also. Then comes the paroxysmal supraventricular tachycardias, the regular rhythm. So, and it's a ratio of PHQRS 1:1, and the heart rate may go up to 130 to maximum 270 beats also. And the P wave may be hidden in the QRS complex or in the T wave, and it will not be seen. And it occurs as a result of excessive stimulation of SA node or atrial excitation outside the SA node, or it can be a nodal re-entry or re-entry through a bypass tract. So that is the reason why the first slide itself I showed the mechanism as automaticity or re-entry is one of the causes for all these arrhythmias, and the paroxysmal supraventricular tachycardia is one of the re-entrant tachycardias. Of course, this is a picture which you all should be able to identify in your OSPE or VIVA commonly given. So it can be a form of atrial fibrillation or atrial flutter, and atrial flutter has a regular rhythm with a P and QRST. It may be in the ratio of 2:1 or 3:1. The normal duration of QRS, heart rates can go up to 250 to 300. And with a ventricular, that is atrial rate will be like that, and ventricular rates will be 150 ventricular beats per minute. And it may have a classical sawtooth pattern, or in atrial fibrillation, it will be like a fibrillatory waves of the P wave, which is called the fibrillatory waves or A wave. And this picture shows what are all the acute and chronic therapy, because this may be an acute condition, or sometimes it may remain chronic also. Atrial fibrillation and atrial flutter can happen in a chronic way in a patient as a so-called persistent or a permanent type of atrial flutter and fibrillation. And this is mainly again a nodal re-entrant tachycardia. And the acute therapy for atrial fibrillation is the vagal maneuver, adenosine or verapamil. And chronic therapy, you have to go for catheter ablation or continuation of verapamil, beta blockers. And for re-entrant tachycardia, you have again, these are the treatments, and basic chronic treatment for these. Now, the pharmacological or synchronized cardioversion is indicated treatment of atrial flutter if the pharmacological methods are not effective. And atrial fibrillation causes an excessively rapid and irregular heart rate. So the differentiation between atrial flutter and fibrillation is it has a regular rhythm. Even though it may be 2:1 or 3:1 conduction, it will happen in a regular manner. Whereas in atrial fibrillation, it will be usually an irregular pulse, which is identified clinically mainly by what is the clinical method of identifying atrial fibrillation?
Checking pulse rate and heart rate simultaneously, sir.
What is that called? Pulse deficit. Okay?
Pulse deficit.
So one person should count the heartbeat, another person should count the pulse beat. There will be a difference. So by auscultation, you count the heartbeat, and then by palpation, you count the pulse rate. If you are a single person, what can you do? Supposing you don't have a helping hand to count the heartbeat and auscultation by auscultation, and you are alone in the OT, and if atrial fibrillation occurs, how will you check the pulse deficit?
ECG waveform with pulse, sir. ECG waveforms with pulse.
ECG waveforms.
Yes, sir. We can look for the monitors in ECG and.
Yes, you can use some part of the monitor, but not ECG. Which part of the monitor you can multi-parameter monitor you can use if you are a single person and you want to identify the pulse deficit. Then put on a pulse oximeter that will give the peripheral pulse rate. and you can auscultate the heart and count the heartbeat. Okay? So if you are a single person, that is the easiest method. So AF can occur in commonly metal stenosis, thyrotoxicosis, alcoholism, ASD. Atrial fibrillation is one of the short note questions that can be asked in the examination sometimes, or even in the clinical viva, they usually ask you. So the causes of that are can be cardiac or non-cardiac also. Atrial fibrillation can happen in non-cardiac conditions also, like alcoholism, chronic lung diseases. Even cirrhosis liver can produce atrial fibrillation. So we can classify them into cardiac and non-cardiac. And causes irregularly pulse with a pulse deficit. And the loss of obvious atrial kick can produce atrial thrombus. So that is the most important danger of persistent atrial fibrillation is formation of atrial thrombus, which can get dislodged and produce a pulmonary or systemic thromboembolism. The treatment of AF consists of three things: rate control, rhythm restoration, and anticoagulation to prevent this thrombus formation. So these are considered as the three pillars of atrial fibrillation treatment: rate control, rhythm restoration, and anticoagulation to prevent thrombus formation. And if it persists for more than 48 hours, before attempting to correct the restore the rhythm with a desynchronization or cardioversion, you have to first anticoagulate the patient and then only do the rhythm restoration by electrical conversion. Okay? So that is a very important fact. It is less than 48 hours, the chances of thrombus formation is less. So if pharmacological methods do not work out, you can go for electrical conversion straight away. Then comes the premature ventricular contractions, and they produce an irregular rhythm, and it is mostly associated with no association with P waves and results from ectopic pacemaker activity arising from the other than the SA node, and it usually produces a wide QRS or a bizarre QRS and is frequently observed during anesthesia. But if it occurs in a occasional one or two PVCs, that can be ignored. It is not of any clinical significance. So a new onset PVC in an otherwise a normal patient, if it is if the person is an elderly patient and if he has had any previous history of coronary ischemic attack or coronary artery disease, then you have to give credence to this new onset PVC, which may suddenly lead to ventricular tachycardia and fibrillation. But otherwise, in a young and healthy patient, ventricular premature beats do not have any significance. Then comes the ventricular tachycardia and fibrillation, which is the most dangerous arrhythmia that can lead to hemodynamic instability and even cardiac arrest. So the heart rate is between 100 to 200 beats per minute. In tachycardia, it will be a regular rhythm, whereas in fibrillation, it will not be regular and the pulse also will be very feebly felt in a very fast rate. So the ratio of P to QRS has no fixed relationship because of the atrioventricular dissociation that we have. Amidrone 150 milligram is used as a loading dose in these cases as the first line of treatment. After the loading dose, 1 milligram per minute can be given as an IV infusion, and it can be also reverted to normal sinus rhythm using synchronized cardioversion in case the hemodynamic instability is present. If no effective cardiac contraction or cardiac output is maintained, immediate cardiopulmonary resuscitation should also be started simultaneously. And the defibrillation, the dose is 200 to 360 joules. If it is biphasic, you can go for 200. If it is monophasic, you have to give a larger current of 360. Magnesium sulfate will be indicated if there is a dosage point, and epinephrine can be used to convert the forced defibrillation just before defibrillation. Uh, so that is usually fibrillation is divided into fine fibrillation and forced fibrillation. So what is the difference between the two? Which is more amenable to correction?
Force fibrillation, sir.
Forced fibrillation responds better to electrical correction because it is a fibrillation occurring in the early stage of myocardial depression. Whereas fine fibrillation means the myocardium is practically not contracting at all. So by giving epinephrine, what you achieve is you are able to stimulate the heart pharmacologically and convert this fine fibrillation into forced fibrillation, which can be restored to sinus rhythm with an electrical current. So that is the idea of giving epinephrine here. So this is how the differentiation. This is purely VTAC where it occurs regularly, whereas this is the fibrillatory waves which are irregular and just smaller in amplitude, and this difference may be asked in the OSCE also for you to identify. And this is a situation which is again produced by this arrhythmia in the ventricle and involved in the situation of prolonged QT interval, and I check the baseline QT interval and check for the drugs that prolong the QT interval before surgery. So that is the reason why this sort of arrhythmia can happen. And the first line of therapy, once you identify it as the torsade point, is the administration of magnesium 2 grams slowly IV, even before you give the electrical conversion for that. So this is how the picture may look like. And the other non-shockable rhythm is what is called the pulseless electrical activity, and it may be differentiated from other causes of cardiac arrest by the ECG only. So this is a normal ECG, and this ECG in pulseless electrical activity may look like a normal complex, almost like a normal QRS. But when you palpate, you don't get any pulse in the carotids or in the femoral or any major vessel. You don't have a pulse, and you don't get a heart sound also. So that is how the PEs are identified, and the causes of that are commonly hypoxemia, hypovolemia, hypothermia, etc. And toxicity, tamponade, tension pneumothorax, thromboembolism, all these things also can cause this. Once a diagnosis of PE is made, specific therapy is to treat the cause. At the same time, you must give adrenaline intravenously, 1 milligram, 3 to 5 every 3 to 5 minutes, along with CPR. So here there is no indication of using your defibrillator. So this is a condition. What is the other condition which is not shockable?
asystole, sir.
Hmm?
Asystole, pulseless electrical activity.
VT without pulse. Okay,
VT too.
ventricular tachycardia without pulse also is a non-shockable rhythm. Only VT and VF are shockable rhythm. Okay? This is a commonly asked question in the exam. And reversible causes of supraventricular tachycardia or non-sustained ventricular tachycardia are, these are all common causes like hypoxemia, hypercarbia, acidosis, mechanical ventilation, pulmonary artery catheter usage, and even insertion of a chest tube can result in that, or light plane of anesthesia, and any shock improperly applied for cautery pads. All these things can lead to this sort of arrhythmia. Sometimes there may be arrhythmias which may be mistaken as a the artifacts which may be mistaken as an arrhythmia, which may be caused by patient movement or electric artery being used, and the ECG monitor lead also can get displaced and produce the thing. So in that situation, always first check the patient's vital signs and particularly feel for the arterial pulse or blood pressure, and then correct the potential cancers before you diagnose an arrhythmia with an artifact in the ECG. So this is a classical example of a arrhythmia that can happen during an electrocardiogram use in the ECG, which may look like a fibrillatory state. But if your pulse oximeter is showing a normal pulse and with a it has got the plethysmographic waveform also, so you can easily ignore or identify that this is a pure artifact instead of arrhythmia that is happening. So that is how you differentiate between the artifacts which can happen. Now coming to the flow chart which is used to always first feel for the pulse. If it is pulse present, no means it is immediately start CPR, identify the rhythm and see whether it requires defibrillation or not, whether it is a shockable rhythm or not. On the contrary, if the pulse is held, then see for the hemodynamic stability, whether the patient is stable or unstable. If the patient is stable, see whether the rate is low or at a fast, brady or tachy. And if it is brady, check for whether he needs atropine or whether he needs pacing. If the patient with a pulse rate of less than 40, then you require to correct it even if the BP is normal. But if the patient's pulse rate is between 40 and 50 and BP is stable and saturation is okay, that means you can wait and watch. It doesn't require immediate correction. On the contrary, tachycardia, see whether it is a narrow QRS or a wide QRS from the ECG. If it is narrow QRS, see whether it is regular or irregular. If it is regular, go for adenosine beta blocker or calcium antagonist or amidrone. If it is irregular, then think of again the other things except adenosine. So adenosine should be used only in regular narrow complex tachycardia. Whereas the other drugs like beta blocker, calcium channel blockers, and amidrone, all can be used in both regular as well as irregular. So amidrone is the safest drug which can be given in any form of tachycardia, whether it is regular or irregular. And if it is a wide QRS, again identify whether it is regular or irregular. Regular, again the same treatment. Irregular, then you can go for DC conversion or protein. But if the patient is hemodynamically unstable and bradycardia is present, you must immediately think of giving atropine and beta agonist like isoprene, dopamine or dopamine, and pacing to be kept ready. And if the patient is unstable with the tachycardia, straight away CPR and synchronization or cardioversion should be done. Coming to the classification of antiarrhythmic drugs based on this is to be pronounced as Vaughan William classification, not Wuhan as you are been mentioning, Damodaran. That VAUGHAN is called Vaughan William classification.
Okay, sir.
And it is the class 1 is fast sodium channels, and they are subdivided into 3 classes, 1A and which is prolonging the action potential. Example is quinidine. Class 2 is shortens action potential like lignocaine, and class 3 has no effect on action potentials. So they all act on the sodium channels of the cardiac myocytes. The second one is the beta blockers, which act on the beta adrenergic receptors, B1 receptors in the heart. And class 3 is potassium channel blockers like sotalol and amidrone. And class 4 are calcium channel blockers like verapamil and diltiazem. Digoxin and other cardiac sites mainly exerter. These are the drugs which are not included, like digoxin, adenosine, magnesium, and what is the fourth one? So this is how the classification is done. And, now they have included these two also as a class 5 miscellaneous. But the older classification is only class 4, up to class 4 is there, and these are the examples. This is again repeatedly asked in the examination. We must be aware of that. Okay. This is the answer for this theory questions, which again repeatedly given in the exam. The various arrhythmias and their causes, drug use, and their treatment. Okay. So don't forget to include the heart block also in your answer.
Okay, sir.
All the other things can be. The other answers are okay.
Thank you, sir.
Okay.